Good day, friends, and a warm welcome to episode 13, season 2 of 4D, that is, Detailed Discussion and Dialogue in Indian Diabetes. Welcome back to the show. And as always, we have an expert speaking with us, sharing information and wisdom with us about how to manage diabetes. In each episode of 4D, we focus on one particular aspect of diabetes care. And today, we'll be talking about chronic kidney disease and diabetes. And to discuss this with us, we have Dr. Nihit Kharkwal. Dr. Nihit is a consultant at the prestigious KGMC, Assistant Professor of Endocrinology there. His academic CV sounds like, the who's who. It sounds like as if it should get a prize from the Nobel winners. KGMC Lucknow graduate, RML Hospital postgraduate in pediatrics, and then DM in endocrinology from Meerut. So, Dr. Nihit, warm welcome. In diabetes, everyone speaks about the heart. They speak about nerves, retina. People speak about hypoglycemia. Some people want to talk about insulin. But what is it about the kidneys? Why have you chosen chronic kidney disease? Is it actually an important topic?
Actually, sir, one of the most important complication of diabetes is chronic kidney disease, and it impacts on it impacts Indian population very much because there is a high rate of mortality and morbidity in Indian population because of that CKD complication, and we need to sort out all the important aspects of CKD in diabetes, and because of that, I choose that topic.
Thank you so much. And like you said, we understand the importance of kidney disease. Even more important than that, we understand the importance of healthy kidneys. There is a Bhojpuri song actually. So for those from across India, Bhojpuri is the language of Uttar Pradesh, where Dr. Nihit is from. There's a Bhojpuri language where the singer sings to his lady love, please give me your heart. But if you can't do that, at least give me your kidney. I'll sell it and become a king. So that is the importance of the kidney, whether we are talking on an academic forum, academic front, or whether we are singing in Bhojpuri, kidneys are important. So, Dr. Nihit, warm welcome once again and over to you. We'd like to learn more about it.
Good evening to everyone. I am here to present few points about diabetes and chronic kidney disease. Next slide. As you all know, that diabetes is very prevalent in all over the world, especially in India. If you talk about the prevalence of diabetes in India, then the prevalence of diabetes is around 9.6%. That means around 90 million adults are being affected with the diabetes. In India, 1 in 11 adults are living with diabetes. Over 53% of the adults are living with diabetes are undiagnosed, and that is a dreadful situation because in other sense, 1 in 2 adults with diabetes are undiagnosed. The number of people with diabetes in India is the second highest in the world. In fact, India is called the capital of diabetes all over the world. Not only prevalence, but mortality and morbidity rates are very high in India. In exam studies, it was found that 700,000 tests were occurred in 2021 in India because of diabetes. If you look into the major risk factors of chronic kidney disease, then we can say that diabetes holds a major position as a risk factor for chronic kidney disease. Around 44% of chronic kidney disease patients are affected with diabetes, followed by hypertension, polycystic kidney disease, various glomerular disease, and various other nephrotic and nephrotic syndrome. If we talk about how increase in blood sugar leads to the progression of chronic kidney disease, we can say that hypoglycemia majorly affects two portions of kidney, that is glomerulus and proximal tubule. In both the parts, glomerulus and proximal tubule, there will be an increase in concentration of angiotensinogen and mRNA. And because of that increasing concentration of angiotensinogen, there will be increased conversion of angiotensin second, and this increased concentration of angiotensin second indirectly leads to proliferation of proximal tubule. Hyperglycemia also directly causes increase in proliferation of proximal tubule. This ultimately leads to increase in concentration of SGLT2 excretion, which leads to increasing proximal tubule reabsorption of sodium. Increase in concentration of angiotensin second also leads to increase in concentration of albumin in urine, and increase in extracellular volume. This leads to hypertension. And these all three factors, that is albuminuria, increase single nephron GFR, and increase extracellular volume, leads to hypertension. This all collectively can increase chances of progression of chronic kidney disease in any patient of that age. By definition, chronic disease is a disease of progressive, irreversible loss of kidney function, in which there is a decrease in GFR of less than 60 milliliter of minute for more than or equal to 3 months, along with albuminuria. Albuminous should be there with the 3 to 6 months of duration, in which 2 to 3 times of albuminuria should be checked. And along with that, there will be some other pathological abnormalities. Next slide. This box depicts the classification and screening methods of chronic kidney disease. As you know, that CKD can be classified on the basis of causes, GFR and albuminuria. If we talk about GFR, then there are 5 classes of CKD on the basis of GFR: G1, G2, G3, G4, and G5. And if we talk about albuminuria, then the CKD can be classified on the basis of albuminuria. And the 3 categories: A1, A2, and A3. In A1, there will be albuminuria of less than 30 milligram per gram, and in A2, there will be value of 30 to 300 milligram per gram, and in A3 class, there will be albuminuria of more than 300 milligram per gram. And on the basis of these two risk factors, that is GFR and albuminuria, CKD can be classified into high risk, moderate risk, and no risk, like very low risk. And this type of classification is also the basis of screening methods. Why? Because in very high risk, screening should be done once in a month or twice in a month. In high risk, screening can be done quarterly in a year, and in a very low risk or no risk group, screening can be done yearly. Next question: who should be screened and how should be screened? In type 2 diabetes patients, screening should be done at the time of diagnosis and then after hearing. But in type 1 diabetes patient, screening should be done only after 5 years of diagnosis and then after hearing. And screening should be done on the basis of GFR and albuminuria. And the CKD, by definition, CKD is all about GFR and albuminuria. Next slide. Now, what are therapeutic strategies for diabetes management? Early initiation of combination therapy is an approach to achieve glycemic goals earlier and delay the deterioration of glycemic control with possible better preservation of beta cell function. There are some novel medication therapy that are being used for the treatment of diabetes, for the prevention of chronic kidney disease, along with diet and lifestyle management. These are DPP-4 inhibitors like sitagliptin, Celsar, Inna, and amlodipine. SGLT2 inhibitors like Cana, Dapa, and Pagliflozin. GLP-1 receptor agonist like glucagon, like peptide receptor. That is there. And what are the mechanisms of SGLT2 inhibitors and DPP-4 inhibitors? SGLT2 inhibitors is the newest anti-hyperglycemic class drugs, and it inhibits aerial glucose absorption. Along with that, it produces glucosuria. It not only prevents hyperglycemia, but also it has an effect of weight management, and it also has a positive effect on blood pressure control. And because of SGLT2 inhibitors causing glucagon concentration increase, there will be no risk for hypoglycemia. If you talk about DPP-4 inhibitors, then this is a novel class drug that has been used for more than 10 years, and it inhibits GLP-1 and GIP. And it also stimulates insulin secretion from beta cells. It inhibits glucagon secretion from alpha cell. It is by nature weight neutral, and it has a low risk for hypoglycemia. So this combination of SGLT2 inhibitors and DPP4 inhibitor is a suitable option for Indian diabetic patients for the following reasons. Because it is safer, it has a rapid onset of action, and it has sustained glycemic control property. It improves both insulin resistance and glucagon function. It also helps with reducing body weight and blood pressure, and it also reduces meal burden, and by that it improves adherence and compliance. And overall, it is a cost-effective combination. Next link. In one study, it was found that dapagliflozin in combination with sitagliptin was well tolerated and it took clinically meaningful reduction in glycemic parameters and body weight that were sustained through 48 weeks of treatment. This graph is clearly showing that dapagliflozin and sitagliptin combination is far better than placebo and sitagliptin combination in respect of VDB SB1C for more than 48 weeks of treatment. Next slide. So we already discussed as SGLT2 inhibitors is an insulin-independent glucose lowering effect. It reduces gastric emptying, and it also decreases glucotoxicity and decreasing carbon. And because of that, it has a role of lowering BP, and it has an also property of increasing sensitivity of glucagon and decreasing insulin resistance. And even it increases glucose concentration by decreasing DPP4 concentration. If we talk about DPP4 inhibitors, then it has a property to decrease glucagon, and by this, it decreases endogenous hepatic glucose output. It also decreases renal vascular oxidative stress, and it improves endothelial function. DPP4 inhibitor also causes increase in secretion of insulin, and it has an increasing effect via GLP-1 and GIP-1. So SGLT2 inhibitors have effect on kidney and pancreas and liver, and by that it decreases risk of cardiovascular morbidity. It decreases body weight and serum uric acid, and it lowers blood pressure. While DPP4 inhibitors have a positive effects on pancreas and gut in respect of hyperglycemia. It is a weight regulator, and because of both the drugs and HST combination, this type of drug combination improves hyperglycemia, have a positive effect of amenorrhea, and this combination decreases serum uric acid, lowers blood pressure without increasing risk of hypoglycemia. So if we talk about benefits of SGLT2 inhibitors, works on various levels. It has a main effect on liver, cardiovascular system, pancreas, kidney, and lipids. And even it increases non-esterified fatty acid utilization and increases hepatic glucose output. It decreases ketogenesis and steatosis, and by this it improves fatty liver. While on cardiovascular system, it decreases arterial stiffness and decreases plasma volume, which leads to decrease in blood pressure. It also improves endothelial function, and chances of congestive heart failure is improved. While on pancreas, it increases glucagon concentration and decreases insulin, and because of that, it improves glycemic control without causing increased risk of hypoglycemia. It also decreases glucotoxicity, and it improves weight loss. In kidney, it has a positive effect on tubular glomerular feedback restoration. It also decreases oxidative stress, fibrosis. It improves diabetes and uricosuriia, while it increases lipolysis and the non-esterified uptake, and it decreases fat mass. Many trials has been done on dapagliflozin, which has clearly shown that it has a positive effect on chronic kidney disease, like DAPA-CKD, declared kidney, and DAPA-HF trial. And all the trials have concluded that dapagliflozin have a positive effect in those patients in which eGFR less than 60 milliliter of per 1.73 meter square. And it also improves motility and motility of CKD patient in diabetic patients. Next slide. Now, how we can adjust doses of SGLT2 inhibitors and DPP4 inhibitors in any patient of diabetic kidney disease. SGLT2 inhibitors can be given when those patients in which eGFR is more than 25, but it may continue if tolerated for kidney and CV benefit until dialysis, and the dose is 10 mg per day. While sitagliptin can be given at a maximum dose of 50 mg per day on those patients in which eGFR is more than 45. If eGFR is more than 25 and you have a 45, then the maximum dose is 25 mg once a day. Glucose lowering efficacy is reduced with SGLT2 inhibitors as eGFR declines, but kidney and cardiovascular benefits are preserved. Dapagliflozin is approved for use at 10 mg once a day with an eGFR of 25 to 45 per meter square. Next slide. So, holistic approach for patients with diabetes and CKD should be with the lifestyle management. There should be a healthy diet. Physical activity should be there. Smoking cessation is utmost important, along with weight management. SGLT2 inhibitor is first line drug for diabetic kidney disease patients, and it can be initiated if eGFR is more than 45, and it can be continued if tolerated if eGFR is less than 20 until dialysis or transplant. Second type of drug is metformin, and it can be used if eGFR is more than 45. Regular assessment of glycemia, anuria, blood pressure control, cardiovascular assessment, and lipid management is also necessary. And along with that, GLP-1 receptor agonist can be tried if needed if individual glycemic target is not achieved. Non-steroidal corticoid receptor agonist like prevalent can be used if albumin creatinine ratio is more than 13 mg per gram with normal potassium. And for lipid management, moderately and high intensity statin should be used. If patient is high risk of ASCVD, then antiplatelet agent should be used. And other drugs like ezetimibe, PCSK9 inhibitor, surfactant XLA can be used.
Thank you, Dr. Nihit, for that wonderful talk. And you very rightfully, very appropriately focused on the kidneys. Like you've mentioned, the kidneys are an important victim of poor diabetes control. But then we can use the kidneys to improve diabetes control as well. We can use drugs which act upon the kidney to help improve not only glycemic control, but also renal and cardiac health also, for that matter.
Yes.
So, yeah, the kidneys become a very important battlefield then in our fight against diabetes and related metabolic issues. There are other questions as well. There is a question regarding the use of SGLT2 inhibitors in non-diabetic kidney disease. The question is, sir, everybody with diabetes who has albuminuria or who has low eGFR or has both of them, do all of them have diabetic kidney disease, or is it possible that there may be a non-diabetic cause?
So actually, diabetes is one of the major cause for chronic kidney disease, but it's not an only cause for chronic kidney disease. There are many other causes like nephrotic nephritic syndrome, like glomerular diseases, like polycystic kidney disease, like hypertension, like recurrent hematuria, and any other organic cause of kidney disease. So it is very important to differentiate in between diabetic kidney disease and other causes of chronic kidney disease. There are some key points by which we can differentiate in between two categories. In non-diabetic kidney disease, there may be or there will be cast in urine, and there may be hematuria, and there will be rapid progression of declining in GFR, and there may be any anatomical problems of kidney. And there are many other points by which we can differentiate in between diabetic kidney and non-diabetic kidney disease. And but SGLT2 inhibitors seems beneficial in diabetic kidney disease.
So some pointers on history, like Dr. Nihita said, rapid decline in eGFR, presence of casts in the urine, presence of hematuria. These may suggest a non-diabetic cause, but irrespective of the cause, SGLT2 inhibitors will help. And the question is there data to support the use of SGLT2 inhibitors in people without diabetes, in people with pre-diabetes?
सर एक्चुअली SGLT2 इनहिबिटर्स का जो मैकेनिज्म है वो डायबिटीज से रिलेटेड ऐसा नहीं है, बट हाँ किडनी को इम्प्रूव करता है विदाउट इम्प्रूविंग विद और विदाउट इम्प्रूविंग हाइपरग्लाइसीमिया, and because of it, it has a beneficial role of non-diabetic kidney disease also. And there are plenty of data. I can't remember the actual data, but there are plenty of data which will point out in the favor of SGLT2 inhibitors in the management of non-diabetic kidney disease.
So the drugs have not only a glucometabolic but also vasculometabolic benefit, and they have been used to reduce the risk of they have been found, yeah, and they have been found to improve endothelial function, to reduce the risk of hospitalization for heart failure, to reduce progression of kidney disease. Sir, there is one question coming from Uttarakhand, and the question is, sir, holy month of Ramzan is going on. Can we prescribe SGLT2 inhibitor like dapagliflozin in Ramzan?
Actually, sir, in my practice, I usually try to avoid SGLT2 inhibitors because of long fasting and because of risk of ketosis in this fasting duration, and we can manage diabetes in those patients by other drugs, and after long fasting is over, we can again add SGLT2 inhibitors in those type of patients. This is my point in this patient.
One more question is, when we combine sitagliptin with dapagliflozin, sir, what are the advantages, and are there any shortcomings or disadvantages of this combination?
सर कॉम्बिनेशन तो एक्चुअली बेटर है बिकॉज डापाग्लिफ्लोजिन का पॉजिटिव इफेक्ट है वेट लॉस में, वाइल सीटाग्लिफ डापाग्लिफ्लोजिन आर वेट न्यूट्रल, एंड डापाग्लिफ्लोजिन और एसिटिविटर हैज अ positive effect of reducing risk of hypoglycemia via increase in glucagon concentration, and because of that increase in glucagon concentration, there will be increase in hepatic glucose output. While the indicators are known to cause decrease in glucagon concentration, and because of that, there will be decrease in hepatic glucose output. And this is a counteraction of the action of SGLT2 inhibitors. And other than that, there will be improvement in glucose level without increasing risk of hypoglycemia in this type of synergistic combination. And this is the cost-effective combination, and it has some in improving kidney function in some extent, because DPP4 inhibitors also can be given in some extent with the eGFR of more than 45. Linagliptin can be given and eGFR of up to 35, and DPP4 also can be given to eGFR.
So a comment coming from Dr. Avinash Sharma from Merit for you. Thank you, sir, for the excellent talk. Sir, when we give SGLT2 inhibitor and DPP4 inhibitor combination, like let us say we give DAPA and CETA combination, is there any drug that is contraindicated with them? Can I give this combination along with insulin? Can I give it along with sulfonylureas and metformin?
I think it may be given with the combination of insulin and with the other type of drugs like sulfonylurea and with the pioglitazone or with the GLP-1 receptor agonist. But I will try to avoid inhibitors with the combination of GLP-1 receptor agonist, because the mechanism actually almost same.
So thank you, sir. So if you are giving a GLP-1 RA and a DPP4 inhibitor, it doesn't make sense to do it together. Though there is a major multinational study going on these days, which is giving both. But otherwise, in practice, it would not make sense to use them together. But thank you, sir, for that clear message. And sir, there are many, many more comments coming up. One question is, can we use this in a newly diagnosed person with diabetes? Somebody comes in, diabetes diagnosed just last week, and patient's HbA1c is maybe 8.5% or so. Can we use this drug safely?
Actually, this drug should be in first as a first line drug in a newly diagnosed patient if there is no economical restraint, and if there is no contraindication present in both patients, like old age, like frailty or any fracture or any type of UTI, recurrent UTI. But and then that it should be, or it may be used in those type of patients if patient is coming in our clinic and the first step, because it has positive effects not only with the to improve the hyperglycemia, but also it has a positive effect on the cardiovascular system and renovascular system.
One comment coming from Ghaziabad, sir, from Dr. Pankaj Agarwal. He says, thank you for your wonderful talk. What you have clarified is the assurance and insurance that SGLT2 inhibitors give us. The assurance of efficiency, efficacy, and the insurance of safety and tolerability. So would you like to comment on this? When we speak with our patients about glucose treatment, diabetes treatment, do they want assurance and insurance together? How can we use these words? How can we use these concepts in English and in Hindi both to convince our patients, to motivate them to take long-term therapy?
सर हिंदी में अगर बोले तो एश्योरेंस तो पेशेंट को देना ही चाहिए, क्योंकि जितना जल्दी हम अगर हाइपरग्लाइसेमिया को ट्रीट करेंगे, जैसे बोला जाता है कि हिट हार्ट एंड हिट फास्ट, जितना जल्दी हम हाइपरग्लाइसेमिया को ट्रीट करेंगे उतना ही हम उसकी बॉडी इंसुलिन के लेवल को प्रिवेंट करके रख सकते हैं, नॉर्मल करके रख सकते हैं, जिससे आगे जाके वो इंसुलिन की डेफिशिएंसी का शिकार ना हो जाए। तो ये हमें उसको एश्योरेंस देना पड़ेगा, जितनी जल्दी हम उसको ट्रीटमेंट करेंगे, जितनी जल्दी हम उसका अच्छे से ब्लड शुगर कंट्रोल करेंगे, जितना लंबे टाइम तक वो अपना ब्लड ग्लूकोज को मेंटेन करके रखता है, उतना ही उसकी हेल्थ केयर इंप्रूवमेंट होगा और उतना ही अदर कॉम्प्लिकेशंस आने के चांसेस उसकी उसमें कम हो जाए।
And the same thing in English, sir, because we have people logged in from across the country.
Sir, assurance, assurance, we should give assurance to the patient, and that patient should try to focus on their diet and lifestyle modification, and should try to maintain their hyperglycemia in initial stage, because by progression of the disease, there will be chances of decreasing insulin level in body, and there will be more chances of developing any other complications because of the hyperglycemia. So we need to take any hyperglycemia initial stage to prevent these type of complications.
This is really important, because our colleagues in alternative medicine, what they tell our patients is, come to us and we will give you wellness. We will give you happiness. But the kind of wellness and the happiness, that they offer is quite short-lived, actually. Ephemeral, it doesn't last long. And what we can tell our patients is, we are giving you a medicine, of course, which will help your symptoms, which will give you good glucose control, but which will also give you a long and secure future, sustained, secure future, and not only for your glucose, but also for your heart, kidneys, every organ. And when we convey this to our patients in this language, then patients understand that we are worried about them, and we are worried about the long-term benefits. With this, Dr. Nihit, I'd like to thank you, but there is one last question. Sir, in your OPD, what is the most common morbidity that you see? Is it heart disease, kidney disease, infections? What are the commonest morbidities that you see in your?
So in my day-to-day practice, chronic kidney disease is one of this major complication of diabetic patients, followed by neuropathy and retinopathy, followed by cardiovascular, because most of the cardiovascular complication patient will go to cardiopathy. So in NOPD, nephrotic complications are more common in neuropathy in my clinical practice.
I think that is true for most of us across the country. So if you are able to identify these in a timely manner, and then tell our patient that we are helping you manage them, we are helping you prevent progression, prevent worsening, that is something that the patient will accept. That is something that will actually do good for all of mankind. With this, sir, I'd like to thank you very much on behalf of 4D. It has been a great experience listening to you and learning from you. We thank you for your mentorship. Before we conclude, sir, any last message that you would like to leave for your colleagues? People from across India are watching you right now.
Sir, first of all, I would like to thank you, and thanks to 4D team for inviting me for this type of conference. And I would like to say that diabetic patient needs to change their diet and lifestyle firstly, and then treatment is necessary, and then patient should trust their doctors that he's taking care of them, and diabetic patients should also take care of their future complication that may happen because of diabetes, and this is my take for those diabetes.
Thank you, sir. And at Endocrine Society of India, we have a dance team. There is a North Zone Bhangra team. So we will expect Dr. Nihit to be joining us later on this year, and we'll dance to the Bhojpuri music, to that kidney song. Yeah, on this happy note, I'd like to thank all of you for having joined us today. Thank you, Dr. Nihit. Thanks to the entire audience for being with us. Together, we become stronger. Thank you, everyone, and